Jan Lee. I am the CEO of the Delaware Health Information Network, and Nancy.
This is Dr. Nancy Fan. I'm on the chair of the clinical DCHI, and on the board of Delaware Center for Innovation.
And I'm show today to describe the State Health Innovation Plan, or the State Innovation Model. Sometimes those terms get used interchangeably, and where the Common Scorecard in particular fits into that. And the primary focus of today's talk is going to be the Common Provider Scorecard. So if we could go ahead and move to the next slide. Very good. So I think I just said that. We're not going to discuss the entire State Health Innovation Plan in detail. I think it's worthwhile for you to become familiar with it if you are not already. But in the interest of time, we're going to try to primarily limit the discussion today to the discussion of the Common Scorecard, and particularly the goals the scorecard. And there are certainly many other components of the innovation model, and comment is welcome on all of those. You may want to ask some questions at the end when we open it up for Q&A about how this fits into the broader picture. But we do want to be mindful of our time and not let it get away from us before we fully discuss the score. So if we go ahead and move to the next slide. Next. So I'm familiar everybody on the call is with the total work that's been going on around the state innovation model, but it's actually been over the last 2 years or so that there's been a real effort around the problems that I think we all know exist in healthcare today, that the rising costs and always at a corresponding rise in quality. And there's just been a huge opportunity for collaboration that has in part been funded through grant funds through the Medicaid Center for Medicaid and whatever CMMI stands for. Anyway, there's a ton of grant money available through CMMI, and these SIM grants are among them. So the first one was a grant to develop the state innovation model, and the Health Innovation Plan was the deliverable from that planning grant. We are in a second grant, which is a testing grant, and we have had an absolutely amazing level of participation from the full spectrum of stakeholders, from the providers, from the hospitals, from the health plans, from consumer groups. It's just been, to me, the level of commitment and collaboration that's taken place to bring us to the plan. And now it's, okay, enough of a plan already, it's time to test it and make it happen. The real desire was to maintain that momentum and maintain that level of collaboration as you move from sort of the high-order, high-level plan to the let's roll up our sleeves and get our hands dirty with actually making it happen. So the opportunity exists, if we can pull this off, to create a $1 billion value through 2020. And the intent is that half of that amount is going to be invested in the system to support the changes that have to occur to turn the ship. A lot of what we hear is, this all sounds good, but it is really hard, and it is time-consuming, and it's costly to implement the changes to make all of this stuff happen. Who's going to support that? So hopefully you'll understand as we go through this kind of where some of that will happen. So next slide. we have, as a process of developing the innovation model, there was a recognition that if we want to continue the public-private partnership, make this happen, there needs to be a leadership or a governance body that is not just inside the state. This can't be a state-run thing, even though the state clearly has a significant state input into this as a major purchaser of care. And so a 1C3 stood up to lead the ongoing effort to support the implementation of the innovation model, and that is the Delaware Center for Health Innovation, or DCHI. The group you see listed here represent committees of the Innovation Center, and the one exception would be the Technical Advisory Group. It's an advisory group because DIN is the executive arm, if you will, for any of the technical resources that are a part of the innovation plan. And DIN already has a board of directors, a governance, and so we can't be a committee of another organization. But there is a technical advisory group composed of representatives of the DCHI board and other stakeholders that have been added to the committee to provide advice on refining and any discussions around technicalities of connection and how that will impact other organizations and so forth. So the others all represent actual committees of the board, chairs and co-chairs, and are soliciting membership that goes beyond just the membership of the board. So it's truly something here for everyone and an opportunity for anyone who wants to be involved at a deeper level to find the place where you belong and roll up your sleeves and do some work. Next slide. So we've heard from providers over the course of time is we know change is coming, but it's rather daunting to get started with the new payment models. You know, the whole idea of pay for value rather than pay for volume sounds good in theory, but it's a pretty big sea change. And who's going to help us with that? Where's money going to come from? And is this going to end up being just a bid for the hospitals and health plans to take over all the independent practices? If there's one thing I've heard loud and clear, it's whatever model we adopt in Delaware can't shut out the smaller independent practices, and I personally take that very much to heart. So as we move this plan forward is to make it easier to take the existing models to scale and genuinely improve the way we deliver care in Delaware. So as part of this innovation plan, there will be $2.5 million invested in practice transformation, literally bringing in people who can help the practices with the hard work of the practice transformation. $60 million to be invested in coordination, and additional investments in workforce, health technology, and population health. So this is not a trivial financial commitment to actually making this real. Next. These questions, and we've certainly heard them from various people at various times, and it's basically, what does this mean to me? What does this mean to my practice? Are payers really going to be there? Are they committed to making the change? Is this going to be something that really improves patient care, or is this just a new way of shuffling the money? The primary care providers are already under tremendous pressure. Here comes another one. And is this going to be just everything rolls downhill to primary care, or will the specialists and will the hospitals play a role in this as well? And the Innovation Center is actively engaged in addressing each of these. We will probably have time to discuss some of these questions in more detail at the end, along with any other questions that you may have about it. But again, the primary focus for today is to discuss the provider scorecard. You probably have many questions about many other pieces of the innovation model, and if there's time at the end, Nancy and I will be very glad to try to address any and all of your questions. And as you can see here, Dr. Alan Greenglass is also on the Innovation Center board, has been actively involved in the clinical from the very beginning, along with Nancy and others. And so we three are certainly resources for you who are on the Innovation Center board and have been engaged in this all along.
Fan, so I'm going to go ahead and take over from Jan here for a little bit. So what we would like to do is show you what the Common Scorecard looks like, how it works, and the measurements that are involved. We spent a lot of time on the clinical committee along with the payment committee looking at these and the metrics that were involved. What we're asking for you during this testing period is, what you think of it. We'll go through some of the details of what we expect from you and why we feel like this would be beneficial to you to help us out with this, and then the timeline that's going to go along with it. Next slide, please. So for the Common Scorecard, obviously a lot of people are familiar with scorecards from multiple different payers. And so on the left-hand side of the slide, you kind of see like things we've heard from providers about scorecards in their previous own scorecards, and what we try to do is from providers kind of distill that down to what can we do to improve this whole common concept of a common scorecard. So we're hoping that in the end, at the end of this journey, and just remember we're at the beginning of the journey, we're building the car as it's moving down the road, that this is going to hopefully be a single integrated scorecard across all payers. Therefore, hopefully when we get to the end, and the end of the pilot project, not likely, at the end of the 4 years, hopefully, it gives you information about your entire panel of patients for all your payers, hoping that we're able to at least streamline the approach for a value-based care delivery, and that the scorecard placement is scorecards you currently receive. Everybody familiar with the triple aim? One thing that the DCHI board is very conscientious of is what we call the fourth aim, which is improving the administrative quality for physicians. So that is like the mission behind the Common Scorecard. Please. Very brief overview of the initial Common Scorecard. We will see the scorecard in a couple of rounds, but if you look at it, when you pull up, what it's going to be is your board on DIN, and it's going to be like one of the pages from it. Once we're able to, we will hopefully be able to provide interactive. We will have 19 measures. That's quality, utilization, and cost across almost the population. It is focused on primary care. We do try to draw from national measures such as NCQH and TMH programs. We're hoping that this can be a single report across the patient panel, and that it will be linked payment over time. If you're familiar with dashboards, a lot of people will see that this is very similar to other dashboards that you might have seen from your own payers. Next slide, please. Final draft of the Common Scorecard is going to look like. So once again, we talked about 19 quality metrics, and essentially we try to break them down into outcomes, the actual process, cost of care, and utilization. The last two, from 16 to 19, are obviously the deeper work process. Measures 1 to 15 are the ones that we really want to get in and start having some feedback and benchmarks to be able to use up from. We put on this where the measure type came from and the source that will be used for the actual payments for each particular practice. I have and discussed at length about claim-based data strengths and weaknesses, if there are any strengths, that, definitely the weaknesses, as well as CPP2 coding, or clinical data, clinical live data, which we know is also work in process when we talk about health technology. But this is very well. With the testing period and feedback from practices as we roll this out, it might not look exactly the same when we get to version 2.0 or 3.0, but, that's one of the things we're hoping you can help us with. Do is show where DIN kind of fits into this, and Dr. Lee's, all this in the tag group. So essentially, when you have your dashboard, obviously the payer's going to have the claims from the providers. They're going to use them and put them into the 19 metrics. They will receive the from the payers. Then the actual portal, that picture kind of the dashboard portal that we'll have, then we'll aggregate the metrics across payers, and that will go up as your dashboard. We'll then be able to access the scorecard and then contact the payers, obviously, about the data mining. If you have questions about, what your contribution is, what your benchmark is, how the actual metric numerator denominator thing, how it works out. Alluded to about what we're trying to do about rolling out the Common Scorecard. So this test and learn phase is in 2015. And so the importance is to test the functionality and ease of it. Once again, keeping that fourth aim in mind. How is this actually helping the physicians? Do these actually align with practice patterns and experience? Some practices might say, wow, those we've already been able to meet. Some practices might feel like, I've never thought about that as a metric. And what tools we can use to be able that can be improved that are easily available as sources. 16, we're hoping to scale this up, and essentially that means on a broader scale throughout the state, incorporate input to the process, collect from a broader group of practices, and then being able to start linking practices to new payment model that will have been established by the payers. And beyond 16, so this is one thing, I think the last point is really that practices will now be able to further integrate this into their normal clinical workflow and being able to look at the metrics, see how they work with it, does it really accurately reflect their clinical data, and through Common Scorecard. So once again, we're hoping that we're able to spread this out to really disseminate this in 2016. This initial phase that we're asking you to enroll in is really where we're hoping that the test and learn is the most important part of it. Some of the benefits of participating in this testing period. Obviously, everybody who's on this call is interested in exactly what we're doing here and what's going on. We have a lot of leverage as far as who stakeholders are, and including the state as well as payers. The benefits for your practice, obviously, you're actually playing an active role in shaping the Common Scorecard, and that is to your advantage. You get an early look at what your data is like in your practice. If you're familiar with how scorecards work, or you're very familiar, all spectrums, you'll at least have a better understanding how these measurements will then be linked to payment. Obviously, there's a lot of benefit across the healthcare system. We're going to make sure that Delaware is ahead of the curve and that we become one of the 5 healthiest states. We're hoping that this will help us shape healthcare delivery and policy in Delaware, and definitely improve the quality. Everybody talks about how, in fact, this is going to be one of the President's pages for the Delaware Medical Journal about how the United States spends so much money on healthcare costs and really not to the betterment of our quality. And as I think as physicians across the state, everybody's about, I want to be able to provide the best practice, best patients, but it's really costing everybody, payers, able to do that? How can we improve on that? So there's benefits on both sides, and definitely for your practice by participating in this. That as we do the scorecard, what we're hoping you're able to do for us. Informational sessions, obviously, will be, this is just the beginning of one, and hopefully we'll definitely have more information about the operational aspects of this, including things like patient attribution, the technical specifications, and the metrics. There are surveys, periodically regarding how is the scorecard working for you, what's the process, do you feel this is a good metric, is this not a good metric? We hope that you're able to provide us some practice reports, and, that the training and the alignment of the metrics with your own practice. I feel this is a great opportunity for when they say, well, does it really matter what I say? Yes, this is going to really matter. There's $35 million from the federal government behind this, plus a whole new nonprofit organization through the Delaware Center for Health Innovation behind this. So we want to hear you. We want to hear what you have to say. Next, please. Timeline. We kind of briefly talked about it before, about the 2015, 2016, and the actual federal grant is through 2018. However, for 2015, this is what we're hoping to do. So the initial sign-up period ends May 1st, and that's for the testing practices, such as these practices that are on the phone call now. We're going to have the baseline scorecard. Everybody's going to get that and the kinks of it for July 2015. Version, hopefully out in October 2015, depending on the feedback we've gotten. And then it ends November 2015. Obviously, once again, the only webinar that will be provided, we will actually have multiple webinars about what's going on and the needs and the feedback of the participating practices. Please. Suggested area that we're hoping that you're able to give this. Usability and satisfaction, expectations and experience. There's actually going to be a short survey at the end of this webinar, and it's going to be the initial way of telling us, is this sound something you're interested in? Do you think this is a good format for you? And then before your areas of feedback could either be by the way, or obviously everybody has received the email information. Email is always easy for a lot of practices. I know for me, I can do it anytime, 24/7. Can you think about any questions that you might have, anything about your experience, positive or negative? That's what we're looking for. So I think that we really should take this opportunity that we have both with the development of the DCHI and the federal grant accelerator, that we can actually improve healthcare delivery, at least in Delaware. The aspiration for the Common Scorecard, like we said, is really to help and other physicians about these payment models, and for us, this is one scorecard that all pay on and that we're able to use for you. Hopefully help us with that, with the testing, and obviously the fit is really participation and testing to you is what you have to say about it, and having that first, having the ability to evaluate it, be experienced with it, see what it actually is going to look like in the end. Next slide. In the question and answer section, this is the format we would like you to do the questions, to present a question. And this is what happens when Dr. Lee and I talk. We talk and we don't want to repeat everything that's actually on the slide. So if we did go too quickly and you have some questions about what's on the slide, or if you have a question about the actual scorecard or how it was developed or any of the metrics, if you just please address to the question would be when you actually talk would be appreciated. Any questions? Yvonne or if else that.
Jeff Simon has a question. Jeff, can you ask your question? Thank you.
Hello?
Will there be additional measures added on by each payer?
Measures added on by each payer? Was that your question?
Yes.
Okay. So currently, no, that is not the plan. The time is we did ask payers metrics actually were. We brought back see what we had in common and could align. However, an example would be maybe metrics of what's in our Common Scorecard, but definitely have the same metrics that we have in our Common Scorecard currently. The final goal is that everybody will agree on at least a core set of common metrics here. The metrics might change, and that might be based on both peer feedback as well as definitely physician feedback. So metrics that we have were not like set in stone. These were metrics that we felt were important, either have been addressed or have not been addressed as healthcare delivery and quality in Delaware.
And to that, this is Jan Lee. So we have heard from some of the payers that they have concerns about whether this will limit their ability to measure things that they have a particular interest in. And so there's at least a possibility that the payers may want to add additional measures for their own plans. What they've all agreed to, though, is that a significant portion of their value-based payments will be by the metrics on the Common Scorecard. And if they choose to add additional ones, we've said, will you at least agree that you will report them through the scorecard so that a part of what we're trying to achieve is that all of the providers only have to go to one place to see all of their scorecard information rather than get it from multiple places in multiple formats. So that may be part of the future versions of the scorecard as we work on it. The version that you'll be looking at will really be just these 19 measures.
Okay, question here. His question is there a breakout scorecard for pediatrics?
Breakout scorecard currently for pediatrics. There was significant input on the clinical committee from practice and pediatrics, specifically Jay Greenspan, who's the chief of pediatrics at Nemours, as well as two behavioral psychologists, Doug Tynan and Tracy Bolander, who also work with children, and now from Christian. So it's not the scorecard for pediatrics.
Many of pediatric measures actually increase cost. Increasing of adolescent well care visits, application of fluoride varnish, which commercial payers don't pay, and no real direct benefit from measuring BMI. Where does the cost savings come from, as the benefits would not be realized until a cohort ages out to adulthood?
So those are good points. I can tell you when you talk about quality metrics and cost savings, there's lots of discussion and debate on either side. I have to say I'm an OBGYN. We consider ourselves primary care. I think when you talk about population health and what we're trying to drive in the state. We quality metrics that we feel would be valuable. There was quite a bit of discussion in the clinical committee about that varnish particular recommendation, and we can use Dr. Simon offline as well as with Jay Greenspan about that in depth. But I think when we looked at what we wanted to include, we were trying to do something that's based on national trends and national recommendations.
From Dr. Kim, two measures are HEDIS hybrids. Are you going to capture that data? Also, how are linked to the payers?
Jan, do you want to answer the part about linking it to the payers, and I'll answer the part about these measures?
The payer will be sending DIN not a full claim, but calculations based on claims. And we asked them the question, so where are you getting the clinical data right now for these hybrid measures? What they said to us was, we get some feeds directly from labs. So they actually get some data directly from LabCorp, for example. And they also send auditors in practices to do chart audits. So they, do whatever sample size they think they need to and use that to calculate HEDIS measures. What we've agreed is, in order to get a version of this scorecard as kind of a least common denominator that can be rapidly developed and rapid cycle testing, we ought to start with where people are now. If whatever sources they use now for the clinical data, that's what we're going to be using in the first rollout of the scorecard. I've been very, very adamant since we first began talking about this, that is not efficient. That is part of what contributes to costs in healthcare, and that what will really be more accurate, more efficient, and less of a burden on the practices in the long run will be if we are able to take the clinical components directly from the EMR of participating practices. That is not the work of a day. That is a work over a considerable period of time. But that's one of the goals that we have for future years and future versions of the scorecard, is that we'll begin to collect the clinical data directly from clinical sources, and that will become the source of the hybrid HEDIS measures and the NQF measures that are direct clinical measures. I hope that answered the question.
Question from Dr. Demore. Scorecards we get from payers now, I will also find significant errors in the data. Is the collection from the payers going to be collected differently than the data that is currently given to us?
Actually answered a bit of that, since it's, probably that's the goal. Dr. Lee, if she wants to talk a little bit more about the platform we're using and the potential for the platform we're using, she can do that. But I know it has the potential to beyond just data mining from claims. And the goal always is, I think, in health technology to use live clinical data. That is the weakness of data mining. That is definitely one of the pitfalls. It's not accurate. It's difficult to make it accurate. There's always that time delay. How is it actually processed? So we recognize that. And that might be the feedback that we get over and over again. I know that is some of the feedback that we talk constantly about in both the payment and the clinical committee, from the physicians who are on it, the practicing physicians who are on it. The limitations. I can actually get beyond that and improve that. It might just be the sheer volume of what we do and how we do it might be the for that. We recognize that, and we're hoping not that is an issue
that probably the first sort of possible for error or source of possible error in the scorecards that you get today is patient attribution. And, you know, you may get a report card from a payer that says you're responsible, you know, for Sally Sue Jones, and you go, I've never heard of Sally Sue Jones, and they say, well, according to our records, she's your patient. And you say, how can she be my patient if I've never seen her? She's your patient because we assigned her to you. Well, that's nice. So, you know, that's one of the very first things that I anticipate will continue to be an issue that will require ongoing dialogue and resolution. And so as we've talked with the different payers over the course of this, they don't all use the same methodology for attribution. Some probably assign that. They basically say, this is your list of patients, and whether you've ever seen the patient or not, they consider that to be your patient. Others look backward and they say, whoever has seen this patient the most number of times, the last, you know, X period, we view that as their primary care provider, and they may not agree with that attribution. So I think that will be one of the things that should be very much on your radar as you provide feedback on the scorecard, because part of what's happening under the hood is that DIN is asking the payers to provide us with files of attribution of patients to specific practices. And part of how the scorecard will be displayed is based on those attribution files that we get from the payers. Well, if the payers got it wrong, you know, you got a problem right there. Forget the data. It's the attribution of the patient is where there's a problem. And then, of course, there's going to be issues with the data itself. The other source where if we're getting all of this in the statements from the payers, they got it wrong, we get it wrong. You know, we get whatever they give us. Part of the reason that we selected the particular technology platform that we selected to display the scorecard is because this company has the capability for doing very much more sophisticated data mining and analytics. And the faster that we are able to switch over to getting clinical data feeds directly from your EMRs to source the measures, the company that we've selected for this display has some very sophisticated query tools and data mining tools that will allow us to transition over time to something that's quite a bit more sophisticated than what you're seeing, what you'll see on day one.
Another question from Dr. Kim. Is screening for depression claims-based?
Yes, currently there was a lot of discussion about how to the screening and what used for it. But yeah, I think, and Yvonne, correct me if I'm wrong about this, we still have a subcommittee actually just looking at this one specific metric. That PT2 code, is that correct, Yvonne? So that's still a claims-based kind of data mining. I think some of the screening for depression is one of the goals of the CMMI grant, and that the Center for Medicaid and Medicare Innovation would like to see greater integration of behavioral health between primary care practices and behavioral health providers. And we wanted to put this out there partly as awareness and partly like really to see what are people doing? Are they doing this? How heavy a list is it? How difficult is it to actually get that information? And what do we need to do as a state to provide those resources? But yes, currently it's the CPT2 code.
Question is from Dr. Gallagher. How will and score screenings, such as colposcopy, where a conversation of risk benefits occurred, but the patient opted to not do the screening test.
So I think for screening, most of them were actually claims-based, based on CPT2 coding, which we know not everybody necessarily has or necessarily built into their EHR. I like certain practices, for example, when you like colonoscopy screening, even if they decline, if you've talked to them about it and you talk about the risk and benefits, then you do it for the actual, you did screening, but you've actually talked to them about it and you can put it. So when you'll be able to see how you actually put this data into your dashboard. Am I right?
The way CPT2 codes work, and part of what I don't like about them is that it's a blunt instrument. It doesn't say the A1C value was 6.9. It said it was greater than 6 and less than 8, or no, it was less than 6, or it was greater than 8. In other words, the CPT2 codes give you sort of broad swaths of information, but you still have to place that code on a claim. And so one of the things that I know is going to be a complaint is that initially this is going to create extra work for the practices to use CPT2 codes if you're not accustomed to doing that already. And so you'll have to learn for these specific measures what are the allowable codes and establish a workflow for entering those codes on the claims for that occasion of service. So again, I think that I just know what I'm going to hear from you is we got to get away from using claims. And the answer will be then we've got to set up some interfaces to get data from your EHR so that we can do the calculations directly on the clinical data.
Question from Dr. Kim, and this is something that you've both touched on already, but is this program going to give us the attribution list, or have to get it from each payer?
Go ahead. Yeah.
I'll go into that. Go.
I'm sorry. From my understanding, the list will be from each payer. And then as part of it's not like working a silo. One of the things that that's over and over and over again from the physicians who participate in the process, both the workshops and in all the committees, is that how do you make this feasible? You need feasible by helping the practice achieve certain goals. And so part of the practice transformation is, okay, so you get the attribution from the payers and then seeing how do you improve your care and quality for not just the people in your attribution, but the highest risk patients, the patients who show up, the patients who don't actually meet any of the quality metrics. So it's all very, very, we as a big integrated picture. And we want everybody to realize that it's a fluid picture. You know, the way it looks 6 months from now might not be the way it looks today. And so I think one of the goals I have is, you know, in the visual, a lot of times, well, my attribution is wrong, and well, you know, you're one physician out of X number. But if a lot of you are saying the same provider don't understand your attribution process, we get it, I think that's something, and this is the process to be able to do it. The simple answer is yes. The attribution comes from the payers, from what I understand.
Get that list proactively as a part of this, and that was the part that I was saying I don't really know the answer to that. So
I think you. So I wrong about that. Because part of practice transformation, you need to know who's actually contributed to your practice to be able to identify, like, the frankly the highest risk or community that you prevent care.
Contribution should be there.
Apologies for jumping around a little bit, but we have a follow-up to the question before about things like colonoscopy. So Dr. Hudson has a question about whether there's a CPT2 code for refusals, such as, and at her practice they're having this issue currently, and she didn't know you could receive credit for screenings if the procedure was not completed.
CPT2 code for specifically colon rectal screening. The claims-based quality for colon rectal screening, yes, you have to be able to either have the op report or the biopsy report in your actual file or a written file to submit for that claim. For screening, like for example, tobacco screening, you do. There is a CPT2 code for that. However, I can't say specifically for colon rectal screening that there is one.
Dr. Kim again. What is the timeline for the EMR-DIN interface? But it's part of the 2016 rollout.
That DIN has applied for a major federal grant. We will learn if by their timeline, we will in the middle of June whether we've received it. And one of the things that we've applied for in this grant is funding to do these connections with the practices. So, fortunately, like almost all of these things, you've got to work with each individual EHR vendor and each individual practice. And so a lot depends on the readiness of both the practice and the EHR vendor to do the work. But if states are kind and we get this grant, we will be ready to actually begin this on a pretty aggressive scale as early as June of 2015. Well, it will be through June before we learn, so let's just for grin's say July of 2015. But we don't want to wait until 2016 to get started developing the interfaces. You're behind the curve if you've done that. What we'd like is to take the rest of 2015 to start working on getting those connections in place and start collecting the data and getting our vendor prepared to do the data mining and the measure calculation so that for a 2016 version of the scorecard, we would actually have the capability for those who are submitting their clinical data to do calculations directly off of the clinical data. So you'll hear more from me after we hear about whether we got the grant or not. There is some funding in the SIM grant to support this work, but the total cost of all of the initiatives in the innovation model is around $130 billion, and the SIM grant is $35 million. So there's always a recognition that the SIM grant alone will not cover all of the cost of implementing the innovation plan. And it was always the expectation that we would seek additional federal funding sources. Some of it's going to come through Medicaid. Some of it's going to come through other federal grants, such as the one I just described. The payers are honestly putting a pretty significant amount of money behind this, and so are the hospitals. So even if we don't get the grant, I would say that all is not lost, but we'll certainly be able to go further and faster if we do get it.
Great. We have a couple more questions about the colonoscopy. So shift to that. I'm going to read a couple of the questions in a row because they're related. So question from Dr. Gallagher. Will this program provide the CPT codes you mentioned? From Dr. Is colonoscopy the only colorectal screening procedure that will be acceptable? And again, will fecal occult blood screening or sigmoid examination be recognized?
So the additional other options for colorectal cancer screening, the other alternative, is a real good question. Actually, I don't think that ever came up in the clinical committee. Can definitely take that back and see what about that. For the code, yes. For the practices who actually enroll, we actually have a library of information, both around how we got around to the Common Scorecard, the data sources for it, and also when we get to practice transformation, when we talk about that, we also have a little library of information regarding that. So we always have looked at ourselves as we are the resource. Remember, trying to make this easier for you, not harder for you. So if one of the feedbacks we get from you constantly is, I've never used that code before, or I have no idea where that's supposed to go, that's things we want to know about. But whatever information we can provide, we will definitely provide that for you.
I will try to this is Jan, I will try to come up with an exact listing of this acceptable CPT2 codes for each of the measures that will rely on those and see if I can get that out to everybody.
Actually, I have that already, like for the clinical committee. So.
Good.
Dr. Simon, back to the pediatric question from earlier. Scores for pediatrics have very low numerators. Dose control for peds is done by endocrinology, as studies show improved outcomes of diabetes specialists in peds. The question is about low numerators.
Right. The hemoglobin A1C. I think we've actually had some recent discussion about that because we have information regarding that. Even in low numerator, and you feel that actually your numbers, you tell us that, like, well, I only had 10 patients show up in the last 3 that actually even needed any of that. And for most who have that particular issue go, they get it. That was one of the issues about the fluoride varnish. Who's going to do that, and what happens if they get that? Their dentists. And so we recognize that. We definitely recognize that. But that's also then if I say, okay, well, that not be a viable measure that lives on the scorecard anymore. Those patients are actually, outsourced to a specialist or don't go to their PCP for that. And that's why we're doing the testing period.
Hudson, will we receive details on how all 19 measures are pulled in, including diagnosis codes and CPT codes?
And we can definitely get back to you about that, but definitely about the CPT2 codes and the claims-based codes, yes, absolutely.
Dr. Simon is following up and saying he has no more questions about colonoscopy.
Yes.
Hear from Dr. Demore. Please explain more about the use of CPT2 codes to data.
We, from our experience and understanding, CPT2 codes are not they live in a little separate. They're actually quality metric codes, and it started when we were talking about PH, NCQF. It's not the same thing as something that might live in an EN code. You score, and I'm going to OBGYN just because that's what I do. You know, vaginitis is a code, and it would be an E&E, like 9213 for a detailed visit. CPQ codes are mostly quality codes, screening, or whether it's like the immunization. So they kind of live in their own little world. I think the goal is to disseminate them more as we go into a payment for value. And from what I understand, and you know, I could be wrong about this, what we understand are metrics codes.
Questions here. So Dr. Fan and Dr. Lee, I think this would be a good time to close out. I know it's almost 6 o'clock.
And do you want to go first?
Sure. So I think there's a next slide that has our contact information. So this would be the way that you could reach either Dr. Fan or Dr. Greenglass or I, and have just general questions, not about the scorecard, but the innovation plan in general. Then that fourth email address would be the place that we would request that you send those questions.
So this is Dr. Fan again. Yeah, the reason we put Alan on here is because both he and I are the co-chairs of the clinical committee, and obviously that is the birthplace of the card. However, if there's specific questions regarding like the payers, there's also a payment committee that we might be able to direct that to. I'm looking for overall general background information. Maybe this is one of the first encounters you have, or touch points you have regarding DCHI or the SIM grant. You can always find that Living in the Healthcare Commission, part of the website for the state government. And I think that any one of us is, if you just have a general question and wondering what's going on, obviously I'm in practice. Dr. Greenglass, you know, lives with CC care. If you're in a healthcare system and want to know how it works, that we have a lot of people in healthcare systems. If you want to ask around and see who might actually be on HI or be involved in it that you weren't aware of, and really if you have any technical or questions, she's definitely the for all of that. But we want that you realize that we want to hear from you. We want your input, good or bad. That is what it's about. And
we're done.